On today's episode of 340 Banter, we're going to be discussing the effectuation of the maximum fair prices as part of the Inflation Reduction Act. Um, Starting in January, we've seen a big change in pharmacy where we're noticing these MFP prices and we're trying to figure it out as we go along. So a lot of things are changing. We're seeing new things every day, but we really want to talk about what we've seen so far and what the challenges and changes to the 340B program are because of the MFP process.
So one of the things that has made a big impact in how the rollout of the initial MFP has gone is the fact that the 340B rebate pilot that had been announced just a short couple months prior, that was going to go hand in hand with the rollout of the MFP, has been put on hold indefinitely. So it could come back anytime, but we don't have that at this moment. And a large part of the plan to go through the deduplication process tied into that 340B rebate pilot program. I think one of the areas of confusion for a lot of folks in the 340B world was once that rebate pilot was put on hold, they thought that the MFP was also getting put on hold. But this is part of the Inflation Reduction Act and was announced years ago. So all of the players in the space, manufacturers, wholesalers, everybody else has had years of notice that this was going to happen, starting January 1st of this year. So it did continue to go into effect. It's standalone, even though it does impact the 340B program. It does stand alone separately from that 340B program.
Yeah, and I think one of the biggest confusion points is who's responsible for that deduplication. When we look at the 340B statute, it's very clear that the covered entity is responsible for preventing a duplicate discount with Medicaid. However, in the Inflation Reduction Act, that is not the same. That's not written the same way. Ultimately, in the Inflation Reduction Act, manufacturers were given the responsibility to deduplicate the claims between 340B and the maximum fair price. So that really puts us in a different situation than we're used to with Medicaid. And I think a lot of covered entities, pharmacists are rule followers. We like a clear rule to follow. A lot of the pharmacists in FQHCs and other covered entities have felt like they have to get that they're responsible for preventing that duplication of discounts just like they are with Medicaid, and that's not exactly the case, and there are a lot of challenges to making it work, if you're trying to make every single claim, match correctly.
Yeah, I think it really comes down to the difference between must and may, or shall, or will. Getting into the legalese a little bit here. And I do know that the pharmacists that I've spoken with have really felt the struggle, like they are responsible for prohibiting or preventing, excuse me, that duplication of the MFP price and the 340B discount up front. And because it is ultimately the manufacturer's responsibility, that that doesn't necessarily need to be put on the covered entity, the 340B covered entity, to ensure that. One of the challenges that we're seeing, though, because that rebate pilot program was put on hold, is that the claim level tie out of the MFP to 340B, deduplication, is not necessarily being reflected, even with some of the data that's being submitted to identify 340B claims. So
Mhm.
some pharmacies are voluntarily attaching a submission clarification code of 20 on the claim to say, hey, this is a 340B claim, as that's going through the logic for effectuating MFP. It doesn't mean that it won't get an MFP refund, because there is still one drug that is across the board where priced lower at the MFP than it is at 340B. So even if it is a 340B claim, there is still an MFP refund. But they're putting that code on to kind of be able to inform the process of where where the refunds should be withheld and where they should be provided. But with that, Logan, do you want to talk a little bit about how we're seeing that actually flow through and maybe not tie out on a claim by
Yeah,
claim basis at
yeah,
this
so
time?
a lot of covered entities had chosen to, voluntarily submit this 20, which I think is great. We're all in favor for working in good faith where possible and providing that discount or that, modifier upfront to help the manufacturers in this process. But what we saw in practice was in the first couple weeks of the year, that 20 was never making it over to the manufacturers. So even though they were submitting it, it wasn't being utilized in the deduplication, which caused a lot of covered entities to be concerned. They're submitting this information, it's still not working. So CMS is working with the plans and the manufacturers to really correct that problem. I think it's still not fixed entirely, but it is in the process. And what we're seeing from the covered entities is that when they're able to, a lot of them are choosing to submit the 20 when a Medicare plan is billed and an MFP drug is used. This is not always possible in the pharmacy software. It really depends on the pharmacy software. Um, but when it's possible, we think it's a great way to work in good faith with the manufacturers. However, there are some concerns with that. If you can't limit it to the MFP drugs or to Medicare plans, that it could create issues in reimbursement models if you're in a state where you have what some people call discriminatory contracting, where you're paid less for 340B claims, that there are concerns about submitting that 20 could come back on the covered entity and be paid less on, some of those claims.
Yeah, and then I think even when the 20 codes are being submitted, some of those prescriptions are still being
Mhm,
identified in Beacon MFP as not 340B, and some of that might be tied to, as you kind of reflected, originally those 20 codes weren't being passed all the way through. In many cases, they are now. I think, as you said, they're still ironing that out. But even when they are being passed through, sometimes they're not being identified as 340B claims in Beacon MFP. And then a lot of times, claims that are not 340B
mhm,
are being flagged as 340B for other reasons. So the Beacon MFP platform has some codes that identify why a claim might be identified as 340B. And one of them is that the claim was submitted with a 20 code. That, the entity identified it or the pharmacy identified it as a 340B claim at the time of transmission or submission. There's also a code for if the claim has been submitted through 340B ESP, just standard data submission processes. I remember entity-owned pharmacies don't need to, for the most part, don't we're not submitting claims data for them, but a lot of the manufacturers have included that they will accept voluntary claim submissions for those. But then also pharmacies be acting as contract pharmacies for other covered entities. So there are instances where those claims are being uploaded.
mhm,
Then we're also seeing some of these claims being identified as 340B just based on historical 340B purchases. So it could be the evidence of an invoice that was timed similarly to when the prescription was filled, but it could just be overall, historical 340B prescription volume, which is really challenging if the covered entity or the pharmacy is the one working to tie every single claim out to say, yes, this is 340B or yes, no, this was not, because it's really difficult to see right now how the manufacturer is identifying that they believe that's a 340B claim. And then to contest something that has been incorrectly flagged as 340B, we're seeing the manufacturers request claims tied to a specific 340B purchase to demonstrate that the claim in question is not 340B. So asking for additional claims data that doesn't have anything to do with this claim. So a lot of challenges and concern in the 340B community, particularly where pharmacists, as you said, are so hard coded for rule following. Really struggling with the fact that even if they're doing their
mhm.
best, so they're submitting their 20 codes to be able to do this, it's still not being applied appropriately, and there's no modifier, there's no identifier for this isn't 340B.
Yeah, and it's proving the absence of modifiers, which is always challenging. It's and I've had several people in the last week ask me, I'm submitting the 20s, but if I have a retail claim, I don't submit that 20 and it's still being identified. So then you're not getting your maximum fair price refund, which can be significant depending on what the drug is. Some of those MFP refunds are $1,200 or more, so it can create a
Yeah.
huge financial, burden to the covered entity.
Yeah, definitely. What we're seeing right now, at least, at the time of this recording, things might change in the, couple weeks that it takes us to get this out. But right now, we're seeing, for the most part, it makes more sense for the covered entity to be monitoring their their overall volume from a percentage standpoint. So keeping in mind, okay, our pharmacy typically runs about 70% 340B. So logging into the Beacon MFP platform should see an SDRA percent around 30%.
Mhm.
They may not tie out on an exact claim by claim basis, but if the percentage is reflective of what your pharmacy typically runs, then it's okay to let it ride because you as the covered entity you're being made whole. The intent of that MFP refund is to make you whole because the payer, the Medicare plan, is only reimbursing you at that rate. So if you paid more than the 340B price and you're getting reimbursed at this lower MFP price, that refund is intended to make you whole. So as long as you're being made whole, or this is coming out in the covered entity's favor, it is okay at this time, especially because this is not the covered entity's responsibility to effectuate the NFP deduplication
Plus,
process.
we
So
we
it's
from
okay
what
to
we've
let that ride.
seen from, from the process, it is quite a a laborious and intensive process to reconcile these claims. It is not an easy
Agreed.
thing. It generally, if you have the information you need, it can take 15 minutes per claim or so to tie it back to the actual prescription that originated it, to really research it. So we don't want covered entity pharmacists to feel like they're having to um, uh, go claim by claim and tying these back because no one needs that stress in their life.
Particularly if the way that you go claim by claim to tie these out involves having to go and identify the claims that were tied to a specific invoice number, because that's what the manufacturers have kind of hinged or pinned this 340B identification on. Um, and then submitting those claims, particularly if you're a covered entity who's not actively submitting claims in 340B ESP.
So a different side of the MFP effectuation is really looking at that dispensing fee portion. Um, there were a lot of concerns early on that the payment methodology would be based on MFP plus a professional dispensing fee. If you're in a retail pharmacy, we take 340B out of the equation for a moment. Retail pharmacy, your only net profit in with one of these drugs is going to be your professional dispensing fee. And what we've seen historically is that Medicare Part D dispensing fees are not great. So CMS heard those concerns and they actually put out a memo back in August saying that those professional dispensing fees should tie out to be more than the cost of the drug itself. It should include things like the overhead, the staffing costs, the packaging. So
I think that's the important part is that it's not even the true profit for the claim, right? So it's not the revenue or the pharmacy actually making money on this. It is truly just to cover the cost of filling that prescription.
Exactly. So what we wanted to start monitoring that to really make sure that we were keeping an eye on it. And what we've seen, to date, looking at a small sampling, it takes quite a bit of work to do this analysis. But looking at about 150 claims a couple weeks into the process, we're seeing an average dispensing fee of about 94 cents. And with the cost to dispense a prescription on average being around $15 in the country, that puts pharmacies at significant underwater. significantly underwater
It's not
territory.
sustainable.
And we're only seeing one, um, payer to date that's paying over $10 for that dispensing fee. If we take them out of the
Wow.
sampling, it skews that 94 cents down significantly.
And what recourse do pharmacies have if they notice that they're being paid a really, really low dispensing fee?
So, that's a great question, and it's something we're working through now, in more of an aggregate level. We've been working with CMS to try to find the correct pathway to get those complaints to CMS. It's as any government agency, things are a little segmented there, and the people that are dealing with the MFP directly may not be the right people to deal with the dispensing fee portion. So we're working through that, but I
Yeah.
think CMS is probably our best course. I don't think that there's a large benefit to going through the PBMs to get that because it is contractual and they're paying based on their contract. However, it's CMS that needs to hold the stick or the carrot, whichever one you want, to get that change made. So I would definitely reach out to CMS. Also, if you're part of a state or national organization for pharmacy, especially NCPA or your state pharmacy association, I'd contact them about your dispensing fees and let them help advocate on your behalf and work with that with CMS in more of a aggregate for many pharmacies together.
I think that's an awesome kinda ending spot and kind of positive plug, for a relatively negative
Yeah,
situation. And I know that this situation will continue to evolve, but at least hopefully this helps folks know that they're not alone, and struggling through this because everyone's figuring it out as we go along. And also, advocacy is huge right now for those dispensing fees.
definitely.